You're listening to the Assembly on Clinical Problems podcast, brought to you by the American Thoracic Society.
So welcome to this edition of the American Thoracic Society's Clinical Problems Assembly podcast, where our goal is to delve deeper into topics that matter to our Clinical Problems Assembly members. I'm your host, Dr. Kerri Johannson. I'm an associate professor in the Department of Medicine at the University of Calgary in Calgary, Canada, and I'm a clinician scientist specializing in interstitial lung disease. On today's podcast, we're going to talk about the documents development process. So the process whereby official documents are proposed and developed through the American Thoracic Society. And I am delighted today to have our two guests join us, Dr. Jolene Fisher and Dr. Kevin Wilson. Dr. Jolene Fisher is a respirologist and clinician investigator at the University Health Network in Toronto, Ontario, Canada, and is chair-elect for the Clinical Problems Assembly Planning Committee, which is the committee that deals with documents that are submitted and proposed to the ATS Clinical Problems Assembly. She's an assistant professor and the research director of the Interstitial Lung Disease Program at the University of Toronto. And Dr. Kevin Wilson is the ATS Executive Vice President of Guidelines and Documents, which means he oversees all aspects of official ATS documents. He's also professor of medicine at Boston University School of Medicine, where he attends in the outpatient pulmonary clinic and the inpatient pulmonary consult service. So thank you both for being here today and for talking us through this process.
Thank you for having us.
Pleasure.
So I thought we could start with maybe Kevin, and I'll just, if that's okay, I'll just go use your first names here, Kevin and Jolene. Good luck, Kerri. If you could outline what types of documents that ATS supports and what each type of different document should be seeking to accomplish, because there's a few different pathways for this, correct?
Sure. So I'll go ahead and start. So the document types that ATS supports are clinical practice guidelines, a variety of different statement types. You have the clinical statement, research statement, policy statement, and technical statement, and then workshop reports. And to describe each one briefly, the clinical practice guideline is allowed to ask 6 clinical questions, and the questions fall into the type of which treatment to use, which population to provide treatment to, which diagnostic test to perform, and which group to do diagnostic testing on. And so for each question, you do a systematic review to inform the committee, and then the committee makes a graded recommendation to answer that question. Clinical statements, they can put together definitions, classification criteria, pathways, diagnostic criteria. That's what they're intended to do. And then let's say research statements are documents that make research recommendations. Policy statements make policy recommendations. Technical statements make technical recommendations, like sort of like a user manual, how to do something. And then workshop reports just report on the outcome of ATS workshops.
That's really helpful. And I think over the last little while, so there's kind of an iterative process. Is the 6 PICO questions, is that a new development in clinical practice guidelines to give a guidance around having 6 PICO questions, or was it always that way?
So it's been that way for probably about 10 years. What happened was that we had guidelines that were in development for 10, 12 years. And that was just totally unacceptable, as you can imagine. And so we did an audit to see how long it would take for various numbers of questions. And what we found is that if you limited the guideline to 6 questions, you could get it complete within 2 years. And that's what we settled on. We wanted to be done 2 years because we have resources to support guidelines over a 2-year period.
I love that you employ an evidence-informed way to address the best way to do guidelines, which is great. And it sounds like the clinical statement part of this, because I think the clinical statement part is a bit new, but it sounds like clinical practice guidelines are making really patient-centric that would impact, diagnostic interventions or treatments whereas clinical statements are addressing topics that have high clinical relevance but are not directly applicable to something that the patient is physically going to be experiencing. Would that sort of be a fair differentiation between those two?
Yeah, I think that that's pretty good. I kind of conceptualize it as clinical practice guidelines and clinical statements are the documents that make clinical recommendations or most closely affect patient care. It's just that clinical practice guidelines are restricted to the four types of questions that I mentioned, whereas clinical statements have a much more flexibility. They can, address pathways, classifications, definitions, diagnostic criteria. You have a lot more flexibility with a clinical statement.
So, Jolene, can you give some examples of what types of these documents come through the clinical problems assembly?
Yeah, definitely. I can, tell you specifically which ones came through over the past cycle that were approved to go ahead. So there were three that came through the clinical problems assembly. One was a technical standard for oxygen titration. Another one was a clinical statement for interstitial pneumonia with autoimmune features, or IPATH classification. And the other one was a clinical practice guideline for the management of acute exacerbation of IPF. And one of the things that we often talk about when we're reviewing the different documents that get submitted in the clinical problems assembly is, did they submit the appropriate document type? So there certainly have been situations where we get a document that was submitted as a clinical practice guideline and we look at it and say, okay, you know what? I think maybe this is more appropriate as a clinical statement. And then we would feed that back to the person submitting the document.
Great, thank you. And that kind of brings into this next process, or sort of the next segue. If somebody were interested in proposing a potential document to be developed through the Clinical Problems Assembly and ATS, what steps should they take? It sounds like maybe you'd want to get some feedback on that before it's actually submitted so that you know you're doing the correct document type. Well, what would be some of the steps that you'd recommend people should take?
I think, well, they could start by listening to this podcast.
Excellent.
But there's a lot of resources on the ATS website under the documents development section. And definitely reach out to us. So we get a lot of emails ahead of the submission deadlines, usually sometime between ATS and kind of the start of summer. People often are emailing us and with questions about a specific idea, whether or not we think this is something that the Clinical Problems Assembly would be interested in. If we have any specific feedback, people will send us their actual proposal ahead of time, which if time allows, we're certainly more than happy to review it and give feedback. Some people I know have reached out to Kevin or we've reached out to Kevin if, there was a question that we didn't have the answer to. So I think looking at it ahead of time, reaching out to us for feedback, making sure that this document isn't already in development, I think would be definitely really important steps and increase the chance of the document going further along in the process.
There are great resources online. So if you go to thoracic.org and then click on the Clinicians and Researchers section under Clinical Practice Guidelines, Statements, and Reports, you can scroll down and then get to this amazing official ATS Documents Handbook. So I highly recommend that anybody that is interested in this or wants to learn more about it, go to this document. It clearly outlines exactly what Kevin was just talking about, the different type of documents, the different objectives that they have, and then the whole process actually. So this is a really, really helpful resource and probably the first place to start, on the website. And then how would applicants go about like assessing need? So would you advise that they recognize that this is something something that needs to be done. It's going to be helpful to clinicians and patients, or policy, depending on the type of document that they're developing.
I don't know which one of us you wanted to answer, but I suppose maybe we could both chime in. But I think from my perspective, I would say if you as a clinician think that there's a need for this, or as a researcher think that there's a need for it, your colleagues think that there's a need for it, then there might be. I think going onto the website and seeing what documents already exist and reaching out to us to see which ones are potentially in development and then bouncing the idea off of the Clinical Problems Assembly Planning Committee or the idea off Kevin. That's sort of what I would suggest in terms of assessing the need. First steps.
Yeah, and it would seem to me that if you think that there's a good question that is really a gap in knowledge in your field, go for it. Probably it is a really important question, and just dive deeper into it and see if anybody's addressed that or not. Because if it's something that really needs to be done, or you think it does with your expertise, it probably is really important. Kevin, is there more of a formal way that people should be assessing need when they're putting their documents together? I guess it's understanding, like, is there an ERS document that's being developed similarly, or is there something from another society? Um, are there any other formal steps that you would advise that they should be taking?
No, I don't think so. I think Jolene's answer was correct. I get not just me, but the document committee gets a fair amount of questions like, would ATS be interested in this topic? And that's not particularly helpful because the answer is always yes. Because ATS has a broad membership and a broad amount of interest. But what I see is in applications and proposals, people tend to support their need based on either gaps, like maybe a previous research statement identified something as a gap, or a lot of times they talk about symposia at the ATS conference that were very popular, suggesting that there's a desire for it. Sometimes it's just a gap in the literature. I've seen a whole bunch of different ways to kind of support the importance of a document. But in general, I will say that ATS is interested in almost anything its members will submit. And what it comes down to usually is how well constructed the proposal is.
And I think there are examples of strong proposals or previously submitted successful proposals on the website that you can link to. And again, another great resource to reach out to people who have submitted one, where you can see what a strong proposal would be. And some of the proposals can be joint initiatives with other societies, right? In what circumstances would that be considered or appropriate?
So I should probably take this one. So joint proposals tend to be very popular amongst the developers. We don't have metrics to actually confirm it, but I think it's generally accepted that they tend to be a little bit more impactful and a little bit more noticed, let's say, by the community, and it's more easily disseminated because it's disseminated by both societies. Those are the pluses. There are definitely some negatives that people that are putting in their proposal should consider. So, for example, a lot of times where the document's published has nothing to do with the proposal. It has more to do with the past history of the two societies and what they've published together. There should also be recognition that usually if you team up with another society, the other society is going to want its own co-chair and probably want about half the committee members. And then downstream, the peer review will go through both societies, so there'll be more peer reviewer comments. And also the approval will go through both societies, which may take a little longer. So there's definitely pluses and minuses. I think I should point out, though, that other than the ATS ERS collaboration, which has its own separate submission pathway, the expectation is that every proposal will be submitted as an ATS only proposal, and then the collaboration will be worked out later. So I'm not sure that saying you're going to collaborate with another organization particularly helps you or hurts you. That's something that would be decided after your proposal is approved.
Okay, thanks. And I think that brings a little bit into sort of the structure of the committee. So when you propose a document, you generally will, it's kind of like writing a manuscript or a grant. It's very similar. You're building a team of people to help bring this project to fruition, and you want a broad range of expertise. Do you have any advice, or is there structure around who comprises the team? So I would imagine it's different for different document types, but do you want to keep it to a certain number of people, a certain key number of people? You want representation across early career researchers and underrepresented people in medicine, or yeah, what kind of approach should people be taking when they're building their team? I guess that could be a question for both of you.
I mean, I will say it's certainly something that we look at when we are reviewing the proposals. And so, Kevin probably can speak to more specifics in terms of like exact numbers, but we definitely look at the size of the committee proposed. And if it's too big, we start to think, okay, is it really feasible to get all these busy people together to execute everything along the timelines that you've proposed? We certainly look to make sure that there's a diverse committee, just like you described. So you don't want all very senior people, but it's good to have some people that have a track record of, developing successful documents. You want to make sure that if you're doing a clinical practice guideline, you have a methodologist and you've clearly identified who that person is going to be, for example. So I would say that these are all definitely important things to consider. Do you have do you need a patient representative? Do you have one? Do you have a multidisciplinary team? So it's not all clinicians, for example. So certainly these are the kinds of things that we look at and discuss.
Yeah, I wholeheartedly agree with everything that Jolene just said. I'm not sure I can add much. I'll say in general, the number of 12 to 25 tends to work. If you have fewer than 12, you may lack some expertise. If you have more than 25, that's when red flags start going up that this may be delayed because of group management. But other than those specific numbers, I don't think I have much to add to Jolene's answer.
Thanks. And is there methodologic support from ATS? Because usually you mentioned that. Is there support if it's a clinical practice guideline, or not necessarily if you've got your own methodologist? Or how do you incorporate methodologic expertise in some of these documents?
Yeah, so ATS actually requires only for clinical practice guidelines, but it requires that there be an experienced guideline methodologist on the panel. The background for that is that in the past, when the standards came out for guideline development, we used to just hand it to the guideline committees and say, please adhere to these. And they struggled with it. And a lot of times they struggled in a way that they didn't even realize they were struggling. And they'd submit it, and all of a sudden they would be met with, this needs to be redone from scratch. This needs to be massively revised. You'll just have to complete it as a review article, which didn't go over very well, as you can imagine. But then when we started putting guideline methodologists on the panel, all those problems went away. So that's where the requirement comes from. And what we define as a guideline methodologist is somebody who has experience leading a systematic review and also leading a grade-based guideline, because grade is the board-approved method for developing guidelines with the ATS. So people with those experiences, sometimes people have those individuals already on their committee list, which is great. It saves me a lot of work. Other times they'll just come to me and I'll try and help them find somebody that's appropriate for them.
Okay, fantastic. And so if someone's going to submit a proposal, let's say for a workshop report or a clinical practice guideline to the Clinical Problems Assembly, is the date set for the deadline of submission already? I think usually it's in end of June or early July. Is that right?
So the proposals usually become available online at the very beginning of July 1st or 2nd, and they're typically due at either the end of July or the beginning of August. We don't have the dates for next year yet. Those will be set shortly.
Perfect. Well, it sounds like it's never too early to start. So if you're thinking about one and you've got a good idea, now would be a good time to start and be, putting your team together and making sure, building that case for need. And then, Jolene, maybe from the planning committee side of things, once it's been submitted, can you tell us what the next step is?
Yeah, so once it's been submitted, basically, the planning committee will get a list of the proposals that are submitted under the Clinical Problems Assembly and some time to review those proposals. And we'll score them. We score the relevance to ATS. So I think it's helpful to have a strong argument, shall we say, as to why this particular document is relevant to the ATS. And then, we'll score things like the methodology. So you do want to make sure your methodology is well described. You have well described timelines. So we all feel confident that this is something that is feasible to complete. We think about the scope. So I think it's really helpful to make sure that you aren't, I would say it's more common for people to go over scope than under scope, so just, make sure that everything that you want to do is within a feasible scope. We look at all the things like, diversity of the committee, and then we score all of those things. So every member on the Clinical Problems Assembly Planning Committee will score it individually, and then we will meet to discuss it and kind of finalize our scores and comments. We rank all the proposals submitted, and then we submit that back. And I think it goes to people such as yourself. So I'd hand it back to Kevin and Kerri. I know you have some involvement in the next steps as well. And people will get a chance to respond to all of the comments before and do revisions before it sort of gets submitted again and the next steps in the process take place.
Yeah, so if I could just add to that, while the process is working as Jolene described, the applications are usually also being reviewed by the document committee. So the document committee really tries to focus on just the methodology, not the content, and leave the content to the planning committee. So the applicants get comments from both the Assembly Planning Committee as well as the Documents Committee. And they're expected to take a look at those comments, address them in the application, and resubmit them. And then it goes to the Project Review Committee, the PRC, used to be the PRS, which will go through and do its own review, its own scoring, and its own ranking. Oh, and if I could just add something Jolene said was very important, and that is scope. My observation over the years has been that scope is the most common downfall of the applications. The applicants tend to want to show that they're being inclusive and addressing a lot of things. And then it works its way down to the PRC, and the PRC has a different agenda. They want to make sure these documents are going to get finished and published in a timely manner, which is more of a focus scope. And so in general, applicants really should resist any temptation to have a very wide scope and try and stay targeted.
And it was my first year on the project review committee this year, so I can jump in a little bit. But once all of the projects have been reviewed, I'm not sure if it's all of them. I think come to the PRC, or if it's like a subset of them. But it was like a kind of a grant review committee over 2 days, and a really large group of people to provide a lot of input. It was very exciting, actually. I really enjoyed it. And we got to sort of be first reviewer, second reviewer, and provide input and feedback. And then I guess at the end of that, I'm not sure where documents go after that. Once things have been scored, does it then go to the Documents Development Committee to make a final decision?
Yeah, so what happens is that Miriam Rodriguez, who's the staff person for the PRC, she'll collate all the scores and rank the projects according to the score and send it to me. And I'll look with the documents committee and the document staff. And what we do is we look for a gap in the scores, like a natural break point. And those that scored above those break point will try to to approve, and those that scored below probably not approve. There is some tweaking that goes on based on the amount of resources that we have for the year, staff time, and that sort of thing. But in general, we find a break point, usually anywhere from 12 to 18 documents, and that's what's approved in a normal year.
Oh, great. And then people get notified, and then I think in like January, maybe of each year, then they get notified and they can start running with the project. Is that right?
Well, so in December, they get just an email saying whether they're approved or not. And then in January, sometimes it spills into February, they'll get a more complete letter that summarizes the PRC review. It doesn't include the Documents Committee review. It doesn't include the Assembly Planning Committee review, just the PRC review. But it's basically a list of how the PRC saw the strengths and weaknesses of the proposal. That way, those that were not approved have something to go with if they want to submit again next year. They have an idea of where they succeeded and where they failed. And in general, the documents that are resubmitted in a subsequent year tend to do pretty well.
That's nice to have that opportunity to revise and resubmit and sort of, yeah, especially if it's your first time and you're like, oh, I didn't know that I should be doing this, or this. That's really helpful feedback. Yeah, and yeah, I think that's all the sort of questions I wanted to address today. I just wanted to see if either of you had any other last comments about something that we didn't talk about, or any other final tips.
I don't think so. I mean, feel free to reach out with, any questions or to get some initial feedback on proposals. And if I don't know, I'll try to find somebody else who does. So.
Yeah, in general, the clinical problems assembly tends to do pretty well. I think that its topics appeal to kind of a large portion of the membership. They always tend to have the most applications, but they always do very well. So I would say if you have content questions, probably to reach out to the Assembly Planning Committee. And if you have more methodologic questions, then to reach out to the Documents Committee.
And I would just reiterate to listeners that the resources on the website are amazing. So definitely start from there. And again, it's like any other application. Think about it early and get external feedback and kind of keep developing it. I have to say, I had a workshop report on exposure assessment tools for hypersensitivity pneumonitis. And I held my workshop in 2019, and it was really quite career changing for me, and a wonderful experience and a wonderful opportunity. And so I'm extremely thankful for the support that I received through the ATS, and this was with the EOPH assembly. And so I'd encourage anybody, if you've got an idea, just to, pair up with somebody who maybe has more experience and run with it, because if you think it's important, it probably really is. So I just wanted to thank. Oh, sorry, go
Do
ahead.
you mind if I just mention two other things? These are changes that everybody may not be aware of. Actually, three things. One is that it used to be in the past that every project would have a full day meeting, face-to-face meeting on the Saturday prior to the ATS conference, and that no longer happens. Most of the projects are completed virtually now. The exception being is that second year guidelines are offered a face-to-face meeting. That was one change. Another change is that there are no longer budget sections for the proposals. It used to be that the proposals had to put in a budget, and that's not done anymore because the costs are kind of spread across different departments in the ATS now. And then the third thing people should be aware of, and this is brand new, and that is it used to be that the publication site was based on document type. So like statements and guidelines would go to a blue journal, workshops would go to a white journal, and the journals have stopped that. Now, every document, regardless of document type, is going to get submitted to the blue journal. The editors are going to look at it and decide which journal it should be eventually published in. So if you're a guideline, you might not get the blue journal potentially. And I guess the flip side is that if you're a workshop, you may actually end up finding yourself in blue journal. Right? It's more of a less of a document type decision and more of a document by document decision.
Good. Yeah, that's helpful. Yeah, so when I did my workshop report, it was pre-COVID and it was everybody was there in person and you had to sort of factor in the travel costs and sort of lunch and stuff like that. But I guess that really cuts out a lot of that sort of extraneous costs too, and allows people who can't maybe travel to attend and participate.
Yeah, it actually wasn't so much cost. I think that with COVID, the way people work kind of fundamentally changed and people wanted to do things virtual. So we tried to return to the all-day meeting. And what happened is that at the last minute, people were canceling and they're saying, I don't want to come in early. Could you give me a link? Can I participate virtually anyways? And we had to cancel meeting after meeting after meeting because there wasn't a quorum. And so that's why it drifted down. It really wasn't money. It was, a way of working essentially.
Yeah, I love hearing about this whole process is so iterative. Like it's like flexible and adaptable and kind of like changes to, best practices and what the people need. And I think we all really appreciate that. So yeah, thanks for those final comments. I just wanted to thank you, Dr. Wilson, and thank you, Dr. Fisher, for sharing all of your insights and expertise. And thank you to the ATS for supporting this podcast. I hope you found it useful.
Thank you for joining us today. To learn more, visit our website at thoracic.org. Find more podcasts from the ATS assemblies on YouTube. Don't forget to like, comment, and subscribe so you never miss a show.